Well, thanks everybody for working with us with some technical difficulties. It's always a desire to share the stage with Shira and Jeff. I'm going to talk about exercise today and just figure we keep this patient centric. So we've heard a lot about from the patients how they're tired of hearing about lifestyle, and I thought if we could focus on the patient and then also talk about how providers can become better educators when it comes to activity and exercise, this would be a good way to do it. So we recently saw a 62-year-old grandmother with diabetes and newly diagnosed at-risk MASH. Like many of our patients, she was relatively sedentary and then consumed a diet that would make Shira cringe. When we talked to her, she said, my primary care provider wants me to lose some weight and start metformin. And, I know exercise and diet are good, but, why would exercise be good for my liver? And, I am here to help us kind of convey that message and then, provide a practical framework for all the primary care providers in the audience that you can employ in your practice. And you may say, well, we've heard a little bit about, resmetirom and semaglutide as the second, recently approved treatment, at least in the United States. But again, like what Shira said, lifestyle modification, where we, watch what we eat and we are more active, still going to be incredibly important, even, as we have more and more medications. And you may say, well, we all know exercise is good, but what can I tell my patient? Well, patients who complete regular activity and at guideline-based amounts that Shira told us about of 150 minutes per week of moderate intensity aerobic activity can expect to lose significant fat from the liver. The great thing about exercise is that in general, it's a weight neutral intervention. So you don't have to really lose more than 2 or 3% of your body weight to actually reduce fat in your liver. If you sustain this over time, you're going to have less MASH activity and ultimately lead to MASH resolution. And then perhaps, as we study people out 1, 2, 3 years, maybe we'll see fibrosis or scar tissue reversal, or perhaps even resolution again without weight loss, although we still don't know the answer to this very important question. Now, it's not just about the liver, right? If you perform regular activity, we heard about cancer prevention, but there are other great things you can tell your patients about. First and foremost, they're going to change their body composition. They're going to have more muscle, less body fat. They're going to become more physically fit. And through doing this, they're going to lower cardiovascular risk, control your metabolic disease much better. And then lastly, it's not always about the numbers, right? It's about how we feel every day. And when patients with MASLD perform regular physical activity, they feel much better across all domains of health, excuse me. Now, if we want to go ahead and deliver all these incredible benefits, we need to improve upon the comfort we have as healthcare providers when we meet with our patients. And a lot of questions I get is how can I best prescribe exercise as a medicine to my patients? At least in the United States where I practice, US medical schools spend 0 minutes teaching future physicians how to prescribe exercise as a therapy. So I don't pretend that I can do this in the next now 7 minutes since I'm getting closer on time with the technical issues, but I'm going to give you a kind of a framework you can think about every time. And for those of you who are part of behavioral interventions or do behavioral intervention research, this framework may be familiar. And it's called SBIRT, where S stands for screening, BI means brief intervention, and then RT means referral for treatment. So let's walk through each of these and how they pertain to allowing your patients to become more physically active. So in terms of screening, the first question is who should we screen? And the great thing is American College of Sports Medicine says all patients with MASLD should be screened for physical activity. And you should do it at every healthcare visit. So quite a lofty goal. So if we're going to do this, we have to have a tool that is widely accessible and it's feasible. So we have what's called the physical activity vital sign. And this 2-question questionnaire, which can be done in less than 30 seconds, will give you a snapshot about how much activity your patient is doing every week. The next question you have is, all right, well, my patient's probably not doing as much activity as they need to be doing for their liver health. What prevents them from doing it? And our research group has developed a specific questionnaire for folks living with MASLD, which through 13 questions, which can again be done in about 90 seconds or less, we can arrive at the most common barriers. And nearly 1 out of 2 people living with MASLD actually don't know how to exercise. 1 out of 3 say they don't have enough time, and 1 out of 5, report that it costs too much. So with screening, once you have decided or learned what your patient is doing, and then looked at barriers that prevent them from doing more, the next question is what can they actually complete? And we're not going to put individuals living with MASLD on a treadmill and do formal cardiopulmonary exercise testing. So we have to have a more widely available and accessible tool. So luckily, researchers at Duke came up with the Duke Activity Status Index, or DASI. And again, this questionnaire is feasible. It's 12 questions. And through this, you can arrive at somebody's current cardiopulmonary fitness. So that's screening. You're going to ask your patient what they're doing. You're going to use questionnaires to find out what prevents them from being more active. And then you're going to figure out what they're capable of doing. As you keep this in the back of your mind, the next thing is, all right, I have to do a brief intervention. And this is really where you get to shine and tell the patient about all the great things exercise can do. But how are we doing in the real world? And the answer is not very good. In fact, only 3 out of 4 healthcare providers actually speak to patients about lifestyle, which includes diet or exercise. When we look at referral to dietitians, only 1 out of 2 living with MASLD get to see a dietitian, and then only 1 out of 10 are referred for exercise counseling. So if you want to improve exercise referral patterns, you have to have another easy tool. So we developed the exercise prescription pad here. It's widely downloadable. You guys will notice there are QR codes throughout today's presentation. So you can take these questionnaires and adopt them into your practice. And you may say, all right, well, that's great, John, but I don't know what to circle. So let's walk through the different parts of an exercise prescription. And we have another framework. It's called FIT, which is easy to remember with exercise. And F stands for frequency, or how often you perform activity. I is intensity, and then time and type are pretty self-explanatory. And shown here are some of the things we've already seen with guideline-based amounts of activity. In the interest of time, we're just going to fast forward through these. But if you don't want to remember all this, there's another great handout from the American College of Sports Medicine, which walks through each of these components that you can circle on that prescription pad, or you can hand this piece of paper to your patient. Now, I know we're in a digital age, so when you give patients pieces of paper or prescriptions, it makes a huge difference. They remember this. We have patients who put these on their fridge when they go home. They bring them back when they see us in the clinic. And if you don't want to do this, there's another tool. You can look online and find, where exercise specialists are. And if you put this all together, where you use your 3 screening questions, that brief handout for your brief intervention, and then a referral for treatment, which can be just as simple as that prescription pad, patients actually become more active. And over 50% will become able to achieve guideline-based amounts of activity over 6 months after you do this simple intervention. And you may say, all right, well, John, I have no time to do this. I have 20 minutes to see a patient. Well, I'm here to tell you can. The screening process can be done while you're seeing another patient. My patients wait a while because I'm always behind schedule, and behind schedule today now at our talk. But again, they can fill this out while you're waiting to go in. And then we're all speed readers. We can go through the data in 2 minutes. In terms of brief intervention, you have to practice this and rehearse it, but you can really talk about why exercise is great in 3 minutes or less. And then 5 minutes is probably pretty generous in terms of how long it takes to design a prescription. Because again, if you have that pad, you circle something that's standardized, you give it to your patient. So again, you can do this, it just takes practice. And if you do this, you can be successful. So let's go back to our grandmother and let's see what actually happened. So we delivered the playbook. We got the questionnaires. We developed an exercise prescription that was personalized and based on this guidance. And like many of our folks, she initially struggled with consistency. But by 3 months, she was achieving the activity that we wanted her to do. And when we saw her back at 6 months, she'd lost a very modest amount of body weight, which she wasn't too excited about. But when we look at her fiber scan, the liver stiffness was much lower, the liver fat was much lower, and she had a corresponding reduction in metabolic risk, which over time, if sustained, would reduce her chance of a cardiovascular event. But the most heartwarming thing she said to me was not, oh, great, I love all these numbers. It's like, hey, can you stop talking? I can't wait to go home. This visit's in the middle of my exercise session. And with that, I think we may have a minute or two for questions. Thank you for your time and your attention.
Thank you so much, Jonathan. We do have a few minutes. And what I was asking Shira, I can ask both of you. I mean, I feel like awareness about food and food quality is going up, but I'm not sure that it's getting any easier to eat healthy food, even if we know more. I mean, what do you think, really at the ground level? I mean, not either based on evidence or just your own experience with, the patients, the people you're seeing. Is it getting tougher with all the options out there, or is it getting better with all we now know about food, including ultra-processed food? Shira, then Jonathan.
Okay, thank you, Jeff. It definitely gets more difficult, and actually, the Lancet papers show increased consumption of ultra-processed food almost in all places and globally. And we know that 50% or something similar to that in most countries of the calories, of the daily calories, come from ultra-processed food, especially among children and adolescents. And that's because the availability of ultra-processed food is growing. The prices are low relatively to minimally processed food, fresh fruits, and it's also very tempting to eat those foods because it's very tasty. It's easy to get. You don't need to have any preparation. It's not time consuming, and the taste is great. And it just
Yep.
increases
Yep.
your appetite. So generally, yes, it is more difficult. I think awareness, education, because you can increase the consumption of minimally processed food, but also environmental change, reducing the prices of healthy foods, supervision on supervising and food
Okay.
labeling on ultra processed food.
So Shira, so what would be your message then to the primary healthcare professional? Because they can't necessarily bring down the food of price and they may even be aware. So what's your very short message to them? What would be one thing they should do? And then Jonathan, the same.
They can have a list of minimally processed food in their clinic, like legumes, fruit, vegetables, poultry, low-fat dairy. I think it's a very simple list. Eggs, easy to prepare, easy, fastly a list of foods that can be
Okay.
eaten and are really healthy and good.
So a list and maybe as I showed, images as well. Jonathan, one key message to primary care physicians, what can they do in the face of all of all this delicious, cheap, unhealthy food?
Yeah, it's really tough when the cards are stacked against you like that. But I would say that primary care providers are pillars of the community, and that if you're going to make a difference, it's going to be kind of more of a grassroots movement and community engagement. And you may be able to establish inroads with local partnerships or co-ops. There are actually things that people are looking at now with mobile food clinics, where healthy foods are actually brought into areas that are typically underserved or unable to access foods that are not highly processed. So I think being aware of these resources, engaging your community, and then having a way to effectively communicate those resources to your patients will enable you to be more successful and make the difference you all want to make.